Good evening. I'm Dave Sargent. I'm a member of the Miracle Living Planning Committee. Welcome. Thank you for coming out this evening. Tonight we will hear from a panel on the subject of all those things you see in TV ads. Is it fact or is it fiction? Before we do, a few things which you may well be aware of already, but I've got to go through them anyway. Please silence your cell phones. Also, we haven't moved the restrooms. They're still back in that corner back there. Our lectures are recorded live so that we can offer daytime showings of the lecture to those unable to join us this evening. Now, if you know of someone that is interested in that, you might tell them that the phone number to call to reserve a spot is 310-517-4711. The video replay will be Monday, April 22nd, this coming Monday at 10 a.m. Reservations are, they really like them to have reservations, but they're not necessary if somebody comes in at the last minute. DVDs are also available for purchase at a cost of $15. And if you're interested in ordering one, there's a sheet back at the table that you walk past on the way in, back there in the back. And you can also see the lecture on demand at the website, which is www.torranceMemorial.org/MOL, as in Miracle of Living. Okay. For those of you that aren't aware, the format is that we will hear from our panelists here, and then there will be a short break after the final speaker. Members of the Miracle of Living Committee will come around with pieces of paper and pencils, if you don't already have them, for your questions. We only take questions that are written down for the question and answer period, because if you yell questions out, they aren't picked up by the microphones, and the poor people that are trying to get it at home don't get the whole gist of what's going on. Okay. Oh yes, last final thing. At the close of the program, we ask you fill out the evaluation sheet and return it at the back table back there. That helps in the planning of future programs. Thank you very much. Our moderator this evening is, where is she? She's right over here. Dr. Mary Beth Miller. So please help me welcome Dr. Miller.
All right, good evening, everyone. I think this is going to be a very fun lecture topic. We've never tackled this before, but I think it's going to spur a lot of thought and questions. So we're going to get started. We're going to hear from our first speaker tonight, Dr. Shahinaz Soliman. She received countless academic awards, has written for numerous publications, and presented at many seminars throughout the United States. She was born in Cairo, Egypt, and grew up pursuing her dreams of becoming a doctor and coming to the United States. She graduated from Ain Shams University Faculty of Medicine in Cairo, Egypt in 1982. She then finished a pediatrics residency in 1992. She moved to the United States at that time. Shortly after, she became a faculty member at Palmer College of Chiropractic West in San Jose, California. There, she was appointed assistant professor, teaching subjects in cardiovascular pulmonary diseases, geriatrics, and radiology. During her teaching career, she was voted Outstanding Faculty of the Year for 7 years. In 1999, she finished her U.S. medical certification examinations. Dr. Soliman is an active staff member for both Torrance Memorial and Little Company of Mary Hospitals in Torrance, California. She holds active memberships in the Academy of American Family Physicians and the AMA. She is the sole shareholder in the Soliman Care Family Practice Center since 2003. In 2013, she co-founded a healthcare technology company called Sphinx Medical Technologies. The company mission is to create software to solve doctors' day-to-day challenges and improve patient satisfaction and access to their doctors. She is also the creator and owner of Spare My Hair, which is a hair loss products to help with the treatment of thinning hair, launched in March of 2015. So as you can see, she has many talents and wears many hats. Please welcome Dr. Soliman.
Okay. Good evening, everyone. Thank you for having me here today. It's my pleasure to be here to speak with you today about fact or fictions in drugs advertisement in TV. So today our lecture will be an interactive lecture. We'll start by giving a quick kind of information about what's going on in the ads in TV. Then I'm going to start quizzing you and asking you to help me out and partner with me in finding out what's a fact and what's a fiction. So let's start now, and I'm sure that none of you watch TV ever without seeing some kind of advertisement about medications every day. And actually, the United States of America is one of the countries that's allowed to advertise about medicine in TV ads. And during that time, when the FDA approved for the drug advertisement to happen in TV, it's required for every drug company not only to mention about the benefits of the medications, but also to discuss in details about the side effects of medications. Drug companies spent over $4.8 billion in 2014 in drug advertisements. And at this point, they have to find out how can they send the message to their patients, to every patient, about the possible good actions of the drug without scaring them away from the side effects of the medications. So all of us, when we watch TV and see a drug advertisement, we find that happy people hugging each other, running around and talking about the great benefits of this medicine and how wonderful it's going to be in our lives. At the same time, they have to find an artistic way of speaking about the side effects. And how they did that is by simply getting people to be interactively standing up, talking about all of the good effects, and then in the background there is a voiceover about mumbling the side effect of the medications. You're going to have nausea, vomiting, headache, brain explosion, and at the end you're going to die. And then we hear that all the time, and then we wonder what's going on. So for any drug, anyway, to come in the market and to be available in our hands, it has to go through different phases, actually a 12-year process to be available in the market. It all starts by a preclinical testing, usually in animals, and that's basically to get the idea, the way that the drug will be metabolized in the body, to find out if it's really going to be helpful in any kind of disease. That usually takes about 3 years. Then once they get and collect this data, they do what we call an IND, investigational drug application, by submitting all of this information to the FDA. That IND usually takes anywhere between 30 days to a whole year to get approved. And here comes all of the trials, the phase 1, 2, 3 of trials. Phase 1 clinical trials is usually happening in healthy people, usually about 80 volunteers, where they start running the whole kind of testing about how the drug is going to be working and how it's going to be metabolized and excreted by the kidneys, and if there is any side effects. That preclinical phase takes about 3 years, followed by phase 2, which is actually more of an actual patients and volunteers. And that's usually about 80 to 300 patients. That also takes about 3 years. Then comes phase 3, and in phase 3, there is more number of patients, actual patients, about 1,000 volunteers. That also takes about 3 years. Then, hold on one second. Then comes the new drug application, which all of this data collected from phase 1, 2, and 3 are sent to the FDA. And that takes 2.5 to 3 years as well by the FDA to approve. Now the drug is out and it's in the stores and it's in the TV ads. Comes phase 4, which is the post-marketing phase, to find out from patient surveys about how the medicine is working with them. Is it a good medication? Is it causing any side effects? And that's when some of the drugs can actually be pulled out of the market if it's not doing what it's supposed to do. So during these 12 phases of investigations, a drug is formed. And actually, at this point, when they do the advertisement, like I'm going to show you right now, that this advertisement will outline exactly what are the effects and side effects of medications. So what are the concerns anyway about drug ads and what are the issues about that? Many people have some kind of concerns about drug advertisements on TV. I have many patients coming saying, Dr. Soliman, we need for you to prescribe for us this medication. I say, but that's not good for you. No. We know what we're talking about. This medicine is wonderful. My friend took it, my neighbor took it, I want that medicine. So there is a possibility of over-prescribing of these medications and can be totally the wrong treatment. Also, it can be very costly for people to buy a drug, and then that drug has major side effects, then go and try another drug, besides all of the cost that comes with prescribing the wrong medicine for patients or giving the patient the wrong education. So we all experience that, and we all have our concerns about drug advertisements and its effect on the healthcare system. I'm going to just quickly give 2 examples that I've been just dealing with in my practice in the last maybe few years, and mostly about aspirin in the last few months. We all know that people has been taking aspirin. Some of them are quite healthy. And lately, there is a very big kind of investigations and research and a string of research about aspirin, 81 milligrams once a day. Many patients have been taking the aspirin, even though they're very healthy, once a day. And they found out in these studies that this medicine is not a good thing to be given. It will cause more harm than good if it's given to a normal person who's quite healthy, who has no risk factors for stroke or heart disease. So the fact is, yes, aspirin should not be given in 81 milligrams for healthy people because it can cause GI bleed, it can cause kidney problems, which is totally unnecessary. However, people with stroke and people with atrial fibrillation, people with heart attacks, people with blood clots, they do need the aspirin once a day. So the other day I found a patient who I know, she had a history of heart attack and had a history of stroke actually, and pacemaker and AFib, and she decided she's not going to take any blood thinners. I saw on TV, aspirin is not good for you. Well, it's not good for you if you're totally healthy, if you don't have risk factors. But if you do have risk factors, then you have to be taking your blood thinner, and in many cases it's the aspirin 81 milligrams. So that's a fact. Another problem that many people or many patients are very concerned about are statins. I have patients, I tell them, okay, your LDL is 250. It's supposed to be below 99. No way on earth I'm going to take a statin. These are really very bad for you. Okay, I don't want to lose my memory, doctor. Don't give me a statin. Well, we tried all of the natural ways. We did diet, we did exercise, we tried the natural things, but you have a very high level of cholesterol. Okay, I'm going to lose my memory. Here is the fact. Only lipophilic drugs that can cross the blood-brain barrier can cause the memory loss. And there are only 3 of those. The 3 medications or the 3 statins that can cause memory loss are Lipitor, atorvastatin, Zocor, simvastatin, and Mevacor, lovastatin. So how about Crestor? How about rosuvastatin? How about Lovaza? How about the other ones? No, those doesn't cross the blood-brain barrier. Only those 3, the Lipitor, the Mevacor, and the Zocor, that can cross the blood-brain barrier and can cause memory loss. So what are the top medications we see every day in TV ads? If you try to surf and look at the TV ads, you might be watching one of those different ads. There are 10 of them, which are the top 10. Cialis, Lyrica, Eliquis, Viagra, Humira, Latuda, Xeljanz, Celebrex, Abilify, and Chantix. Does any of those ring a bell? Any of you heard of these names before? Definitely, okay. So let's see what the ad says
When the moment's spontaneous,
when it comes to
why
Cialis.
pause to take a pill? Or stop to find a bathroom? Cialis for daily use is approved to treat both erectile dysfunction and the urinary symptoms of BPH, like needing to go frequently, day or night. Tell your doctor about all your medical conditions and medicines and ask if your heart is healthy enough for sex. Do not take Cialis if you take nitrates for chest pain, as it may cause an unsafe drop in blood pressure.
You can
Do
watch
not drink
the
alcohol
screen
in
while you're
excess.
seeing the voice
Side
over.
effects may include headache, upset stomach, delayed backache, or muscle ache. To avoid long-term injury, get medical help right away for an erection lasting more than 4 hours. If you have any sudden decrease or loss in hearing or vision, or any symptoms of an allergic reaction, stop taking Cialis and get medical help right away. Ask your doctor about Cialis for daily use and the free 30-tablet trial.
So you saw here that they're showing happy people throughout the ad, even though they're saying bad things. You saw here that they're saying it's not going to protect you from HIV. And now people start thinking about the HIV and what's going on while not listening to the rest of the story. So you're just seeing happy people thinking about something else. There's a complete distraction of what this ad totally said. So, fact or fiction? Do you think Cialis can be used in people who has enlarged prostate, the benign prostatic hyperplasia, as well as ED? Yes. Fact or fiction? Yes, it's a fact. It's a fact. Cialis can be used especially in men who has ED and has enlarged prostate. Is Cialis safe for everyone with a heart disease? What do you think? Fact or fiction? Fiction, totally. Actually, if you have a heart disease, or if you're taking nitrites, or if you have any heart condition, do not take Cialis. Now, is Cialis can be used in patients using the same class of drug who has pulmonary hypertension? I don't know if you've heard or not, but from the same class of drug, they came up with Viagra and Cialis with a medicine to treat people with pulmonary hypertension. It's the one that's used from Cialis is called Ancestrycom. Do you think people who are taking Ancestrycom for pulmonary hypertension can still take Cialis at the same time? No. So that's a fiction, totally. Okay. And can women take Cialis, you think? No. Fiction? Fiction. No, it's a fact. Yeah, it's a fact, and it's a fact because women can have pulmonary hypertension and can take Cialis. Not Cialis, but the Ancestrycom. So something coming from the same family. It's basically the same thing, but for pulmonary hypertension. Okay, let's see the next one.
People, I look like most people. But on the inside, I feel chronic, widespread pain. Fibromyalgia may be invisible to others, but my pain is real. Fibromyalgia is thought to be caused by overactive nerves. Lyrica is believed to calm these nerves. I'm glad my doctor prescribed Lyrica. For some, Lyrica delivers effective relief for moderate to even severe fibromyalgia pain and improves function. Lyrica may cause serious allergic reactions, suicidal thoughts, or actions. Tell your doctor right away if you have these, new or worse depression, unusual changes in mood or behavior, swelling, trouble breathing, rash, hives, blisters, muscle pain with fever, tired feeling, or blurry vision. Common side effects: dizziness, sleepiness, weight gain, swelling of hands, legs, and feet. Don't drink alcohol while taking Lyrica. Don't drive or use machinery until you know how Lyrica affects you. Those who've had a drug or alcohol problem may be more likely to misuse Lyrica. With less pain, I can do more with my family. Talk to your doctor today. See if Lyrica can help.
Okay, so Lyrica, we've all heard about Lyrica. And Lyrica is a medicine that actually is used for nerve pain, whether it's after shingles, whether it's caused by neuropathy for any cause, including diabetes, and also it's caused in fibromyalgia. The ad, of course, because it's FDA approved for fibromyalgia, they just basically market it as if it's just a fibromyalgia medicine. Many people stop using Lyrica because of swelling in their hands and feet, as far as I saw. But it's a good medicine for neuropathy unless someone has a side effect or a contraindication to use Lyrica. Let's see here what's a fact and what's a fiction. Is Lyrica FDA approved for fibromyalgia? Yes, I just said that. Yes, it's a fact. Can Lyrica treat nerve inflammation? Yes, it's a fact. Can Lyrica cannot be used to treat epilepsy. What do you think? Well, Lyrica, when it was started and was discovered, it actually was a medicine for epilepsy. So yes, so Lyrica can be used to treat epilepsy. Lyrica doesn't affect our memory. What do you think? Is it fact or fiction? Well, it's a fiction. And can Lyrica be addictive?
Yes. Fact.
To some extent, yes. Okay, so let's see what's next here.
I've always been about what's next. I'm still giving it my best, even though I live with a higher risk of stroke due to AFib, not caused by a heart valve problem. So if there's a better treatment than warfarin, I'm up for that. Eliquis. Eliquis is proven to reduce stroke risk better than warfarin, plus has significantly less major bleeding than warfarin. Eliquis is FDA approved and has both. So what's next? Seeing these guys.
Don't stop taking Eliquis unless your doctor tells you to, as stopping increases your risk of having a stroke. Eliquis can cause serious and in rare cases fatal bleeding. Don't take Eliquis if you have an artificial heart valve or abnormal bleeding. While taking Eliquis, you may bruise more easily, and it may take longer than usual for any bleeding to stop. Seek immediate medical care for sudden signs of bleeding, like unusual bruising. Eliquis may increase your bleeding risk if you take certain medicines. Tell your doctor about all planned medical or dental procedures.
Eliquis, the #1 cardiologist prescribed blood thinner. Ask your doctor if Eliquis is what's next for you.
So Eliquis, I think for many people was a blessing, because people who used to take warfarin and Coumadin and taking all the time their INR testing at the per time and watching all of the different vegetables and the things that they have to eat which can interact with Coumadin, when they came up with Eliquis, everyone was liking the idea or is liking the idea. You notice in this ad, they didn't say one of the most major side effects of Eliquis. They didn't even mention it at all, which is the spinal hematoma, which is bleeding around the spinal cord. We didn't hear that at all in this ad, which is one of the most dangerous complications of Eliquis. So Eliquis in general, it's a quite safe drug, and if you are the good candidate for it, it does help prevent any further thrombotic episodes, any further heart attacks, any further thrombotic strokes. So let's see what here is a fact and what here is a fiction. You should take Eliquis if you have an artificial heart valve. Is that a fact or is it a fiction? Yeah, should never take Eliquis if you have an artificial heart valve, never. Eliquis should be stopped a week before your surgery. Is that a fact or a fiction? Who says fact? Raise your hands. Who says a fiction? Some people not saying anything. Well, actually, it's only 2 days. Why? Because that's the lifespan of the medication. So do not stop a week before the surgery, just 2 days before the surgery. You can stop Eliquis on your own without consulting your doctor. Do you guys think it's a fact or a fiction? Yes, it's fiction for sure. Eliquis can increase your risk for bleeding. Is that a fact or a fiction? That's a fact. Okay, perfect. Let's go to the next one. You all are becoming physicians now.
You've reached the age where you know how things work. This is the age of knowing what needs to be done. So why let erectile dysfunction get in your way? Talk to your doctor about Viagra. 20 million men already have. Ask your doctor if your heart is healthy enough for sex. Do not take Viagra if you take nitrates for chest pain. It may cause an unsafe drop in blood pressure. Side effects include headache, flushing, upset stomach, and abnormal vision. To avoid long-term injury, seek immediate medical help for an erection lasting more than 4 hours. Stop taking Viagra and call your doctor right away if you experience a sudden decrease or loss in vision or hearing. This is the age of taking action. Viagra. Talk to your doctor.
Okay. So I played that as well because it's one of the top 10 that are played all the time on TV. So again, facts or fiction for Viagra, it might be very similar to Cialis. Is it okay to take Viagra and nitrates at the same time? No, that's a contraindication. Excellent. Is Viagra is expected to harm an unborn baby? Like, for example, someone's taking Viagra and the wife conceived. Would that harm the baby? No, it won't. So it's not going to harm the baby. Is it okay to drink alcohol and take Viagra? No, of course not. So it's not okay. So that's a fiction, and no alcohol and Viagra combined. Now we hear about Humira.
Proof of less joint pain.
And clearer skin.
Proof that I can fight psoriatic arthritis.
With Humira.
Humira targets and blocks a specific source of inflammation that contributes to both joint and skin symptoms. It's proven to help relieve pain, stop further irreversible joint damage, and clear skin in many adults. Humira is the #1 prescribed biologic for psoriatic arthritis.
Humira can lower your ability to fight infections. Serious and sometimes fatal infections, including tuberculosis and cancers, including lymphoma, have happened, as have blood, liver, and nervous system problems, serious allergic reactions, and new or worsening heart failure. Tell your doctor if you've been to areas where certain fungal infections are common, and if you've had TB, hepatitis B, are prone to infections, or have flu-like symptoms or sores. Don't start Humira if you have an infection.
Ask your rheumatologist about Humira.
Go to mypsaproof.com to see proof in action.
Okay, so Humira, as we all heard, and we know that this is one of the now very commonly prescribed drugs for rheumatoid arthritis, and it works like all of the medications for rheumatoid arthritis to decrease the immune reaction, the autoimmune disease against the joints and other body parts. So it's an immunosuppressive medication. People use sometimes, like they start with methotrexate for rheumatoid arthritis, and then if it doesn't work, they go and just start prednisone, Humira, all of the new medications for rheumatoid arthritis we have. So what's here is a fact and what is a fiction? Is Humira is used to treat many inflammatory conditions. Is that true or not? Yes. Humira can improve the immune system. Correct. Yeah. So that's totally a fiction. That it decreases the immune system. That's why if someone has infection, tuberculosis, cancer, they cannot take Humira. Now, Humira can cause lymphoma. Yes, because it lowers the immune system, so the lymphoma can grow and can start and can be like causing also other types of leukemias, and other types of cancer can be more metastatic if they're taking Humira. Humira can be used in children. Is that a fact or is it a fiction? That's a fact. Yeah, Humira can be used in children with juvenile rheumatoid arthritis. Okay, so let's go to the next one. Latuda.
If you're struggling with bipolar depression, there are treatment options. Ask your doctor if once-a-day Latuda, lurasidone HCl, may help you. In clinical studies, Latuda has been shown to be effective for many people struggling with bipolar depression. Latuda is not for everyone. Call your doctor about unusual mood changes, behaviors, or suicidal thoughts. Antidepressants can increase these in children, teens, and young adults. Elderly dementia patients on Latuda have an increased risk of death or stroke. Call your doctor about fever, stiff muscles, and confusion, as these may be signs of a life-threatening reaction. Or if you have uncontrollable muscle movements, as these may be permanent. High blood sugar has been seen with Latuda and medicines like it, and in extreme cases can lead to coma or death. Other risks include decreased white blood cells, which can be fatal, dizziness on standing, seizures, increased cholesterol, weight, or prolactin, trouble swallowing, and impaired judgment. Avoid grapefruit and grapefruit juice. Use caution before driving or operating machinery. There are paths to treat bipolar depression. Ask your doctor if once-a-day Latuda for bipolar depression is right for you. For savings options, visit latuda.com.
Okay, so one important thing about Latuda that I need to totally stress on, that Latuda, if it's given to a patient with dementia, it can cause death. So Latuda should never be used for someone who has dementia. They didn't mention that. And that's a very important point that we should know about. So Latuda is used for bipolar depression. What is a fact here and what is a fiction? Latuda is used to treat dementia. I just asked, that's a complete fiction. While you are taking Latuda, you may be more sensitive to temperature extremes such as very hot or very cold. Is that a fact or is it a fiction? She mentioned that. No? Yes? Yes, it's a fact. Okay, and also drinking alcohol is safe with Latuda? Most medications, you cannot drink alcohol with most of these medications. So that's a fiction. Is Latuda indicated for bipolar disorders and schizophrenia? Yes, totally yes. I agree. So let's go to
It's
the next
simple
one.
physics. A body at
It's one more
rest
after
tends
that.
to stay at rest, while a body in motion tends to stay in motion. Staying active can actually ease arthritis symptoms, but if you have arthritis, staying active can be difficult. Prescription Celebrex can help relieve arthritis pain so your body can stay in motion, because just one 200 milligram Celebrex a day can provide 24-hour relief for many with arthritis pain and inflammation. Plus, in clinical studies, Celebrex is proven to improve daily physical function so moving is easier. And Celebrex is not a narcotic. When it comes to relieving your arthritis pain, you and your doctor need to balance the benefits with the risks. All prescription NSAIDs like Celebrex, ibuprofen, naproxen, and meloxicam have the same cardiovascular warning. They all may increase the chance of heart attack or stroke, which can lead to death. This chance increases if you have heart disease or risk factors such as high blood pressure or when NSAIDs are taken for long periods. NSAIDs, including Celebrex, increase the chance of serious skin or allergic reactions or stomach and intestine problems such as bleeding and ulcers, which can occur without warning and may cause death. Patients also taking aspirin and the elderly are at increased risk for stomach bleeding and ulcers. Do not take Celebrex if you've had an asthma attack, hives, or other allergies to aspirin, NSAIDs, or sulfonamides. Get help right away if you have swelling of the face or throat or trouble breathing. Tell your doctor your medical history and find an arthritis treatment for you. Visit Celebrex.com and ask your doctor about Celebrex for a body in motion.
Okay, so Celebrex, as we all know, is used to treat arthritis. It's another NSAID, but it probably works better than ibuprofen and Aleve and Motrin and all of the other NSAIDs we know about. It does have the side effect of GI bleeding. It does have the side effect of kidney problems. So if someone has a kidney insufficiency, they are not candidates to take Celebrex. Okay, so what's the facts or fictions about Celebrex? Is used to treat pain or inflammation caused by many conditions as arthritis, ankylosing spondylitis, and menstrual pain. Is that a fact or a fiction? That's a fact, I agree. Celebrex may cause stomach or intestinal bleeding. Is that a fact or a fiction? Excellent. Is Celebrex can be used to treat some cases of colon polyps? Have you heard of that? Yes, it's a fact. It's a fact. Yes, it's used to in some cases, and actually I have a personal history. My mother had colon cancer, and I was shocked when the oncologist gave her Celebrex after she finished the treatment, and there are some studies about the correlation between Celebrex and colon polyps and colon cancer. So the answer is yes. Celebrex is safe in people with kidney disease? No, that's a fiction. I agree. Okay.
It's tough to quit
Okay, that's
smoking.
okay.
Cold turkey.
Here's my favorite one.
Chantix can help you quit slow turkey. Along with support, Chantix is proven to help you quit. With Chantix, you can keep smoking at first and ease into quitting. Chantix reduces the urge, so when the day arrives, you'll be more ready to kiss cigarettes goodbye. When you try to quit smoking, with or without Chantix, you may have nicotine withdrawal symptoms. Stop Chantix and get help right away if you have changes in behavior or thinking, aggression, hostility, depressed mood, suicidal thoughts or actions, seizures, new or worse heart or blood vessel problems, sleepwalking, or life-threatening allergic and skin reactions. Decrease alcohol use. Use caution driving or operating machinery. Tell your doctor if you've had mental health problems. The most common side effect is nausea. Quit smoking. Slow turkey. Talk to your doctor about Chantix.
That's a good one. Okay, so let's see here. What's a fact or fiction about Chantix, the medicine we use to help to quit smoking? Taking Chantix, this is a fact or a fiction. Taking Chantix, you can never have the nicotine withdrawal symptoms. What do you think? That's a fiction, I agree. You can continue to smoke for 1 week while taking Chantix. That's a fact, actually. That's the way we prescribe it. We tell the patient, go ahead and smoke for 1 week before your quit date. And yeah, so say, for example, Saturday, today is what? Today is Wednesday. So say next Wednesday is my quit date, then I can start taking Chantix today till next Wednesday and then stop smoking. I never smoke anyway, but just that's for the knowledge. You can do that 1 week while taking Chantix. Okay, another fact or fiction. Chantix is safe if you have history of depression. Is it safe? Yeah, it's a fiction because Chantix is contraindicated actually in people with history of depression. So I have a patient who is smoking and depressed. I say, no, I cannot give you Chantix. Sorry, let's think about something else. So it's contraindicated. Okay, I'm quickly going to give you some idea because I thought that's part of my slide, but we do have Dr. Lauren here and we have Dr. Felix as well. So I'll just quickly say that genetic counseling versus genetic testing. The genetic counseling is a counselor has many wonderful kind of roles when it comes to patient care and counseling. They actually are the ones who can advise patients of what kind of family history they have, what they can be predisposed to, what kind of genetic testing they may need. It may involve or may not involve genetic testing in the session. They're the ones who can translate the findings of genetic testing to a patient and offer support and more information about it. I'll let Lauren talk about that in the upcoming slides, but that's just a quick thing. I wasn't sure if I need to do this slide or not. Also quickly about the new kind of thing that's going around and the popularity of 23andMe, Ancestrycom, Helix, all of this is becoming very, very popular. And last Christmas, it's one of the top lists of gifts that was given in at Christmas time for many people. 23andMe might not be as beautiful and as exciting as most people think. The reason for that, number one, it doesn't diagnose anything. It shows the risk factor. Number two, it's also a kind of invasion of privacy in a way that 23andMe was bought by GlaxoSmith. And you find at a certain point, I don't know what's going on now, but people were denied life insurance and some kind of health insurance has been increasing the prices because of the findings that happened with the DNA of 23andMe. So I think Lauren will be talking more about that, what's a fact and what's a fiction, but that's from my research about it and how it works. I think it's invasion of privacy. It can jeopardize the possibility of life insurance and health insurance. And besides, all of the data can be shared with a third party. So just conclusion for my lecture from today is diseases can cause morbidity and mortality. Medication that can treat diseases are not innocent either and do carry the good and bad effects. The key is which one is more likely to do the harm, the disease or the medicine? When should we take the medicine and watch for the risks? When can we weigh the risks and benefits? We are here to guide you and advise you as physicians. Do no harm is our oath and definitely our goal. Thank you very much.
Thank you, Dr. Soliman. I forgot to mention at the beginning, if there's anybody that has any hearing issues, there are some aids that we have back at the back. If you need something like that, don't hesitate to go visit Mary in the back. So I'm going to introduce Lauren Rudichuk. She is the new oncology genetic counselor at Torrance Memorial Medical Center. She joined the team at Torrance about 2.5 months ago when she relocated from Canada. She grew up in Calgary, Alberta, and completed her Bachelor's of Science degree in genetics at the University of Western Ontario and her Master's of Science degree in genetic counseling at Northwestern University. She then returned home to Canada to work in a large genetics clinic that served patients from northern Alberta and the Northwest Territories. She is now relocated back to Torrance and is the only genetic counselor at Torrance Memorial Medical Center. She's excited about implementing alternative service delivery models for genetic testing and counseling for hereditary cancer in order to expand access to genetic services in the South Bay. Please welcome Lauren.
Hi, everyone. Thanks for having me here today. Let's see if I can get this started. There we go. All right. So I'm going to be talking to all of you guys about direct-to-consumer genetic testing. So thanks for a bit of the intro from Dr. Soliman about some of the things I'm going to be talking about. 23andMe is one of them, probably a test that many of you guys have heard of from looking on the news or watching different shows or seeing it in stores. It's become very, very popular. So we're going to be talking more about some fact and fiction regarding these direct-to-consumer genetic tests. So you also might be wondering, what is a direct-to-consumer genetic test? So I do want to kind of compare a couple different types of genetic testing that's out there. So direct-to-consumer, often what we'll call DTC, genetic testing, is testing that's initiated by a consumer. So you don't need a doctor, you don't need a genetic counselor, you don't need anyone to order this. This is something you order yourself. So oftentimes it's ordered online. You'll go onto one of these fancy websites, put in some information. They'll usually ship you a kit, a little saliva kit. You spit into a tube, you send off your DNA to that company. They'll then analyze your DNA for a variety of different things. Usually these DTC testing companies will use a type of genetic testing called genotyping, or what we call SNP testing. I'll talk about that a little bit more in a minute, but it's often different than a lot of the genetic testing that we're doing here at Torrance and in the clinic here, what we consider clinical or medical grade genetic testing. And oftentimes this is usually something you paid out of pocket for, that your insurance is involved in this testing in terms of payment. Then in the middle, we have something called patient-initiated testing. So this is when someone wants genetic testing. They might initiate it, go online, go to a certain company and order it, but it still has to kind of have a physician sort of in between being involved. So it might not be your doctor who's ordering it, but sometimes they'll have third-party kind of medical services where a doctor kind of oversees it and they're involved in it, but it might not be your primary care doctor or another physician ordering it. This type of testing might usually more involves full sequencing, full kind of more comprehensive genetic testing, and it may or may not be covered by health insurance, or sometimes it's paid out of pocket. So you might have seen potentially a lot of advertising for a genetic testing company called Color. You may or may not have, but that's one of these sort of middle ground patient-initiated testing, but still sort of involving some level of healthcare professional. And then on the far end, we have provider-initiated testing. So this is when a healthcare professional, such as a physician, a genetic counselor, will recommend and coordinate your genetic testing for you. These are more considered diagnostic testing, or can still be pre-symptomatic or predisposition testing, but it usually will kind of give you more clear answers than some of the direct-to-consumer testing will. And this is often covered by health insurance if you meet certain criteria. So genotyping versus sequencing, you can kind of think of this like taking a couple chapters of your book of DNA and looking at it in different ways. So genotyping is only going to look at certain letters in those chapters of your DNA. It's not going to look at all of them. It's going to take a little snapshot of a couple of those letters. When we compare that to sequencing, that's a kind of clinical grade, medical grade genetic testing that we're doing, where we're reading through every single little letter of certain chapters of your DNA. So maybe we're looking at one gene, maybe we're looking at 100 genes, maybe we're looking at all of the genes in your body, but we're doing it in a much more comprehensive way. And with genetic testing, we're basically looking for kind of errors or differences in your DNA. So when we're reading all the letters, words, and sentences, we can look for missing letters, extra letters, missing words, full extra sentences. We're getting a better look. A lot of direct-to-consumer genetic testing companies like 23andMe are using this technology on the left-hand side, the genotyping, just little tiny pieces they're getting a look at. So here's kind of a smattering of different genetic testing companies, direct-to-consumer genetic testing companies out there. You can see a lot of different names, big ones being 23andMe, Ancestrycom, but there's a lot of different things out there. And there's different tests for a variety of different things. So we can see tests for wellness, things like restless leg syndrome. I can probably already tell you I have that. I probably don't need a test to figure that one out. Ancestry, so a lot of these companies really started out with doing ancestry testing, and now some of them are including more of this other sort of trait wellness variety of different things they'll look for. Some tests will look at carrier status to see are you a carrier for a certain disease such as, cystic fibrosis, Tay-Sachs? So you don't have the condition itself, but if you're a carrier, could you and your partner potentially, if you're both carriers, pass that on to a child and have a child with that condition? We can also see direct-to-consumer testing for paternity testing. We can see various trait testing, what kind of earwax you have, dimples, what kind of wine you like. Again, I'm not sure the whole science behind that one, but there's companies out there who will tell you that. So, and then we have health risks. So that's really what I'm going to focus on more, because that's the kind of part that has very little oversight and has potentially very large concerns in terms of doing this type of testing for healthcare risks. So again, just to give you a little perspective on the number of people who are getting these testing done. So kind of gradually started increasing since 2013, but you can see here in 2018, I guess it's sort of hard to see here, I apologize, but this is from an article that was looking at Ancestrycom, one of those companies, and also all major testing companies. So as of 2018, we have about 7 million people who have been tested through Ancestrycom, and then about 12, what's this one? Is that working? Oh, I think it's dying. Okay, well, you can kind of see it up there. The top peak there, it's about 12 million people who've had testing through various companies. So this is just increasing exponentially over the years. So we're also going to play the little fact or fiction game. So if you get a direct-to-consumer genetic testing and you're negative, let's say your results come back as negative for a specific health condition, that means you are no longer at risk for that health condition. Is that fact or is that fiction? Fiction. Yay. Yes, fiction. So just to illustrate that a little bit more, so 23andMe started offering testing for the BRCA1 and BRCA2 genes. So some people thought, great, we're getting testing for these really important genes and we'll find out if we have a mutation in them. And they come back and it's negative and say, great, I'm off the hook, no worries. I have a family history of breast cancer, but it's okay because I tested negative. That's very, very incorrect. So 23andMe only tests for 3 of the Ashkenazi Jewish founder mutations. These are 3 particular mutations in these 2 genes that cause a significantly increased risk of breast or ovarian cancer if you carry them. But this 23andMe, it's not reading all the letters of those genes, it's looking at 3 of them, and so it does not include the 1,000 other mutations that could be present in those 2 genes. And it also does not include the many other genes that can cause hereditary breast and ovarian cancer. So if you were to get clinical genetic testing due to a personal or family history of breast or ovarian cancer, we would typically test you for at least 8 to 10 to 20 genes, different genes related to breast and ovarian cancer. So by no means is this type of testing comprehensive at all. And so this might help to show it a little bit better. Again, this is not, oh, here we go. Okay, so if we take the world population, it's still dying, okay. 7.7 billion people do not have Ashkenazi Jewish heritage. So really this test is not useful for them. Why are you testing for something that you're not really, thank you. Will this help? Oh, okay. Oh, thank you. Which one is it here? And then, okay, there you go, thank you. Okay, so 7.7 billion people in the world do not have Ashkenazi Jewish heritage. That's not the right test for them to get a 23andMe if they're worried about breast and ovarian cancer and the risk of a BRCA mutation. Around 11 million people do have Ashkenazi Jewish descent, and so if they take the test, about 2% of those will actually have one of those 3 founder mutations. So about 1 in 40 individuals of Ashkenazi Jewish descent carry one of those founder mutations. So let's say they receive a positive result. Well, they still have to confirm that with a clinical test. It's still, even though 23andMe is FDA approved, it's still, even on their website, says if you get a positive result, this must be confirmed in a clinical laboratory. On the flip side, you have 98% of people receiving a negative result. Well, that still doesn't rule out their risk. They could have a different mutation in BRCA1 or 2, just even if they are Jewish, or they could have a mutation in another gene. So again, all of this comes down to you must get a clinical test. So I don't know why we're doing it starting from here. It's not the right test, okay? So genetics, again, is only one small piece of the puzzle. It's not the whole picture. And so another thing, 23andMe also recently started offering testing for diabetes. So this just came out, I think, sometime in the last month. They're now offering, again, their same technology, SNP-based testing, looking for little differences in your DNA. And they're looking for something called a polygenic risk score. So they're analyzing about 1,000 different little parts of your DNA that are different between people. So let's say a lot of the population has a letter A at a certain position in the DNA, and some people have a letter T. And they've done testing and seen, okay, a bit more people who have diabetes have the letter T than the people who have a letter A. Don't have as many people have diabetes. So they kind of combine all of these SNPs, all of these small differences in your DNA, and try to give you a score as to, do you have a high risk of diabetes based on a variety of all these little genetic risk factors, or do you maybe have a lower risk? But diabetes, like a lot of health conditions, is very complex. Genetics is, again, one small piece of that, and we don't even really fully appreciate or understand the complexity of the genetics and environment mix. And so there's a lot of other non-genetic factors that are really important. They're kind of major risk factors for diabetes, things like poor diet, lack of exercise, and obesity. So even if you... SNP stands for single nucleotide polymorphism. That's when I was saying where some people in the population at a certain position in your DNA will have a letter A and other people have a letter T. So it's kind of just variation that is common and occurs in about more than 5% of the population at a certain space in your DNA. And so, but again, that's not the whole reason for diabetes. A lot of it is these other environmental risk factors. So really a negative or low risk result from a direct-to-consumer genetic testing really can provide some false reassurance because it's not taking into all of those pieces of the puzzle. So if your DTC test results are positive for a certain health condition, do you think you will develop that condition with 100% certainty? Is that fact or fiction? Fiction. Good. Fiction. So again, most of the direct-to-consumer genetic testing like 23andMe is looking at risk factors, and they're looking at predisposition. So nothing on that test is diagnostic for any health conditions. It might say you have a bit of a higher risk of something, but it does not mean for certainty that you will develop that condition. And again, it's providing you a risk estimate with very limited information. It's taking a little piece, a little couple letters, or hundreds or thousands of letters, but still of your DNA, and giving you an estimate, but not looking at what's in your family history, what's your personal risk factors, what's your environmental factors. It's not putting all of those together. So it also might be a false positive. So you could undergo genetic testing through one of these companies and get a positive result, but it might not even really be positive. So some people have been doing downloading their raw data files from companies like 23andMe. So not only are they getting what 23andMe is reporting to them in terms of some of the risks, some of the different health conditions, but they might actually download that file and get kind of a lot of data and then go put it to a third party who then will give you more information. But these third-party websites, they even say on them that they're really only suitable for research and education, but some people still might use that to think that they potentially have some sort of genetic mutation. So there was a study done, I can't remember exactly when this was, a year or two ago, that found people who submitted their DNA to these sort of third-party places, they found that about almost half of the time those were false positives. So they thought they had some sort of gene mutation in a particular gene that was concerning, thought they were being diagnosed with a medical condition or had a very high risk of that condition, and found out when they were tested again at a clinical genetic testing laboratory, it was negative. It wasn't even there. It was just a false positive. Also, it might just be a scam. So there was a interesting report from an NBC News reporter. He sent in his dog's DNA to a company called Origin, who was testing for a superhero test that was supposed to tell him the strength, intelligence, and speed that he had. This test did not know this was a dog, and they sent him back a 7-page report saying that she would have muscle force would be probably great with quick movements like boxing and basketball, and that she had cardiac output for long endurance bike rides or runs. It was a dog. So you also have to be very kind of cautious of where are you sending your sample? Is this just even fraudulent? Is this even a real company? What are they doing? What are they giving you in terms of results? So again, positive results from DTC testing must be confirmed with clinical grade genetic testing. And then one or two more things. If you send in your DNA sample to different companies, you may get different results. Would that be fact or fiction? Yeah, exactly. So ancestry DNA testing, really how this works is that these companies will compare your DNA samples to other people who have lived around the world for kind of in certain areas for many generations. But these results are really kind of more accurate for sort of continental origins, less so much for country-specific origins. And really that accuracy will depend on how much data exists for that location. And also different labs may be looking at different markers. They may be using different data sets to compare your DNA to. So you can see here this one person, I think again it was a news reporter, sent in their DNA to 2 different labs and got 2 quite different results. So kind of, again, these things are fun. There's, just kind of take everything with a grain of salt though. And you should be prepared for possible unexpected results from DTC testing. True, fact or fiction? Yes. Be very ready for something if you aren't prepared to find out things about family members and non-paternity, and you didn't know you had a sibling or a cousin or someone that you could potentially match with and you didn't know you were related to. There's been countless stories about this in the news. There's whole support groups that have been now dedicated to this entire phenomenon of people getting testing through these companies and finding out whole new family members that they were not expecting to find. So be prepared if you're going to be doing this, that you could find some new information and surprises about your family. So just in summary, not all genetic tests are the same. Most of these DTC health tests are not comprehensive, and you may be missing very important variants in other genes. So really not recommending to be using this for health information, for fun, entertainment, that kind of stuff. But if you have concerns about personal history, family history of healthcare conditions, get referred to a genetic counselor, a physician, someone who can make sure we're ordering the appropriate and correct test for you. And again, a positive result does not necessarily mean you'll develop the condition. A negative doesn't eliminate your risk for that condition. Your results could be different depending on the lab. And just be prepared for unexpected results. So please always think before you spit, okay? There's a few considerations. I won't go through those all there, but they're on the papers if you guys want to read them. Things to be thinking about if you are going to be doing testing. And if you need to find a genetic counselor, that's where you can find one too. I'm one and only here, so there's other ones out there if you're looking for more help in this area. Okay, thank you.
It certainly sounds like buyer beware. All right, this is going to be a fun introduction. Felix Pham, PhD, has been a practicing pharmacist since 2010 and has been with the Torrance system since July of 2016. He specializes in critical care, but currently serves as the clinical supervisor for the Torrance Pharmacy Department. In his spare time, he finds pleasure in long-distance running. He is a new father enjoying the 2nd year with his daughter, Florence. The best parts of his day are mornings when he wakes Florence up for stretches and the evenings for bedtime stories before bed. Please welcome Dr. Pham.
Good evening, everyone. So I wanted to start off with some disclosures. I find that the best way to start a conversation is build a bridge of trust. So I wanted to disclose all of my biases and possible conflicts of interests. So I do work for Torrance Memorial. I do get paid a salary, but this is not part of my job description. I'm not getting paid extra to be here. Providing education to the community is part of my pastime pleasure. It's not something that's actually part of my job description. And I do have a wife that works at Cal Optima which is the largest health insurance provider in Orange County, and subcontracts to this PBM called MedImpact. So I know a little bit inside of that, and I will be talking a little bit about pharmacy benefits managers a little later in this slide. So just to let you know that I'm part of that discussion. So the objectives today are to go over one single drug commercial and then dissect it. I'm going to be looking at the side effect profile and ask ourselves, I'm going to be asking some hard questions like, which of these side effects am I supposed to be paying attention to, since there's so many side effects? And also discussing a little bit about clinical trials, the pitfalls, and the good and the strengths as well that come from it. And also discussing the post-marketing data and what it means to us in the community. Also, because there's just so much information, and I know that we're looking at fact versus fiction, but it's an evolution of information that is coming to you at a very rapid pace. And so what I've done instead is help to create a strategy of how do I manage this type of information as it comes to me, so I'm not a victim of misinformation or information that is evolving and being put into or being cornered into a spot where I might be harmed by taking a drug that I didn't know could harm me. And then lastly, the question that gets asked of me a lot is, why are drug prices so high? I actually don't know. But we'll be going through some of the studies that looked at drug pricing and market forces here in the United States, and then discussing those things in a bit of detail. All right, so I wanted to start off with a drug commercial, and this one's for Invokana.
If you struggle with type 2 diabetes, you're certainly not alone. Fortunately, many have found a different kind of medicine that lowers blood sugar. Imagine what it would be like to love your numbers. Discover once daily Invokana. It's the #1 prescribed in the newest class of medicines that work with the kidneys to lower A1C. Invokana is used along with diet and exercise to significantly lower blood sugar in adults with type 2 diabetes. It's a once daily pill that works around the clock. Here's how. The kidneys allow sugar to be absorbed back into the body. Invokana reduces the amount of sugar allowed back in and sends some sugar out through the process of urination. And while it's not for weight loss, it may help you lose weight. Invokana can cause important side effects, including dehydration, which may cause you to feel dizzy, faint, lightheaded, or weak, especially when you stand up. Other side effects may include kidney problems, genital yeast infections, urinary tract infections, changes in urination, high potassium in the blood, or increases in cholesterol. Do not take Invokana if you have severe kidney problems or are on dialysis. Stop taking and call your doctor right away if you experience symptoms such as rash, swelling, or difficulty breathing or swallowing. Tell your doctor about any medical conditions, medications you are taking, and if you have kidney or liver problems. Using Invokana with the sulfonylurea or insulin may increase risk of low blood sugar. It's time. Lower your blood sugar with Invokana. Imagine loving your numbers. There's only one Invokana. Ask your doctor about it by name.
So who wants to start taking Invokana? I mean, that commercial convinces me, right? There's happy people. They even told you the side effects very slowly, and listed them all out. Couple of things about Invokana. This is an old advertisement. It was released in 2015, and at that time you heard things like #1 prescribed new class of medications for diabetes. And to me, that sounds like if you had an only child, and I only have one child, I would say Florence is my favorite daughter. So it twists kind of the wording around to make you feel like this is the #1 drug for diabetes. Also, I just wanted to mention that Invokana spent $101.2 million in TV advertisements for in the year that it was released in 2015. And it was money well spent, because in the fourth quarter of 2015, their revenue stream increased to $348 million in the final quarter. So it's quite a lot of return just to invest that much in advertising to people about this drug, this new drug. You get this return. And then the other thing to notice is that the side effect list is very small, and I want people to pay attention to that. The smaller the side effect list is, you have to question, well, how new is the drug? The newer the drug, the smaller the side effect profile, which means that you don't know everything about Invokana quite yet. So let's move forward and just look at everything that they had listed. Even though it's a small, and this is a small side effect profile, by the way, you can see that it's still pretty, that's a lot of words on a page. So I tried to break it down into what am I supposed to be paying attention to. So they gave you how it worked. And so sometimes what I tell patients is, well, look at how the drug is working. Then you can focus on, well, what are the likely side effects that you're going to see. So here's another view of it, and I crossed out all the jargon that might confuse people and just highlighted the things that you wanted to pay attention to. And it's all the things that would work or would come up because it's affecting the kidneys. Changes in your urination, kidney problems. But there's still something kind of weird about this, because the language is very vaguish, right? Kidney problems. What is that? I don't know what kidney problems is. And then there's another one that says increased cholesterol, and that's just really off to the side. Like, how did it impact cholesterol? And then the last one I highlighted in red, right there in the bottom, weight loss. Not intended for weight loss, and yet can cause weight loss. I would warn that any drug that is advertising to you that can cause you to lose weight, or you're pitching to you that this is a great weight loss medication potentially, is something that you should be very cautious about. Any drastic changes in weight are concerning, at least from a healthcare standpoint. You always want to lose weight in a healthy way, where it's intentional, it's slow, and it's long-lasting. And it's a combination of the drugs that you're on, the exercise that you do, and the diet that you're taking. That's going to be the healthy way to approach weight loss. So if a diabetic, and most diabetics may have problems with weight, they see this commercial and they say, oh, well, it can cause weight loss. Then you think about how. Well, if it's affecting the kidneys and is causing changes in urination and can cause you to be dehydrated, how do you think that weight loss is going to happen? A lot of water loss. So is it the type of weight loss that you want to see happen? So these are all big questions to ask ourselves. And then I'm going to try to tackle these things as we go along, as the model to how do I approach medications that are being advertised to me that might be applicable to me, and how do I approach it to my physician. So the thing that I really like to emphasize is, when you see the list of medication side effects, you want to have a strategy to approach the side effects when you discuss it with your physician, because you'll be talking about much of what Dr. Soliman had talked about, risks versus benefits. And so you should understand all of the risks, how to manage the risks, and are you willing to take these risks for the potential benefits? So you may have all the risks actually happen to you and none of the benefits, and it truly depends on you, right? Because each patient will be impacted by the drug very differently. So this is just words on a page, but this is kind of how I tackle things. So if you're going to be placed at risk of dehydration because you're going to have a lot of water loss, then you should drink more water. Kidney problems I mentioned here, not specific enough. It's hard for me to tell you there's a managing approach if you don't give me a very specific detail on what it is that we're dealing with kidney problems. Infections. I put a question mark back here. Good genitourinary hygiene? It's unclear to me how to manage this, because if you think about it, what we're doing is we're spilling sugar into the urine, and sugar is a great growth medium, so it can cause infections. How do I manage that, I think cholesterol, it's one of those things. If it impacts cholesterol by increasing it, then basically you would check, and then take your medications, and then decide at what point is the risk of your cholesterol increase going to outweigh the benefits of the anti-diabetes medication. So those are just a few examples. So where do all of these side effects come from? This is a very good place to start. So this is where the clinical trials come in. Clinical trials are good because this is how we measure what's happening to patients before the drug actually releases. But then it also has its pitfalls. So Dr. Soliman did go over this clinical trial list. And after phase 3, when it goes for a new drug approval, that's when it gets released to the public. And then we are all currently in this phase 4 study. Welcome. So we're all part of this post-marketing data. And I think what's very powerful is pay attention to that post-marketing data that comes out, because it's real-world people taking this drug and real-world events happening. And just also know that along the way, there's this institutional review board that does look at all of these clinical trials and then decide whether or not they're ethical, feasible, and so forth. So the pitfalls. So who is tested? In these clinical trials, up to phase 3, patients with and without disease are being tested. Who's not tested? So patients with disease who also have extreme conditions, like extreme ages, very young, very old people, or people with a lot of other disease states, like heart failure or kidney failure. So those people are not being tested, and yet those people might need to know what the risks and benefits are if they're at the end of all of their drug therapies and they need another drug. So I like to emphasize clinical trials with this particular study, and this is a lot of jargon too, but let me just try to explain it. It's the parachute study. It's a very famous study. I learned it in pharmacy school. It was repeated to me in several other seminars, and it's a very good example of what can you believe, what can you not believe. And so this parachute study looked at all of the existing data that exists in the spectrum of the internet universe, and they wanted to see if a gravitational challenge would a parachute prevent death from a gravitational challenge from very very high up if you gave a person a parachute versus a person without a parachute. And they concluded that there was not enough evidence to say that it was effective. So that's because there's not enough studies out there. So who would study giving a person a parachute and giving a person not a parachute? No one would do that. So this is a good example of watching out for those parachute studies, because it's there. It could be very sensible to us that a particular mechanism of action isn't good for people with these conditions. And it's very clear to us based on our training, our knowledge of the body, and the way drugs work. And again, this is applicable for just something more real world. But again, we do a lot of these studies, and then there's a lot of papers that get published that say, oh, well, we don't really know, or it's still very vague to us. So I'll be going over more of that kind of thing. So this post-marketing data here shows that at the end of 2015, they finally came out and said, all right, the FDA has enough evidence to show that Invokana can cause too much acid in the blood and serious urinary tract infection resulting in hospitalization, which is much different than kidney problems, right? Or the infections that they had listed. It seemed like maybe a slap on the hand, but this is some serious stuff. To be hospitalized for a urinary tract infection is a big deal. I believe so. And then acid in the blood seems also like a big deal. It's a little hard to explain what acid in the blood means to a diabetic, but there's this condition called diabetic ketoacidosis, and it's a pretty serious condition, and it can be life-threatening. It's somewhat related to that, but it's not exactly that. So you're looking at conditions that patients would want to avoid as a diabetic, but now are faced with more and are more likely to have because they've taken this drug. So there's this irony that is now beginning to build, right? And so now here's the first
Have
lawsuit.
you suffered kidney damage or ketoacidosis from Invokana? The FDA has warned that Invokana and other SGLT2 inhibitors may cause serious injuries, including ketoacidosis, which may lead to kidney failure, hospitalization, coma, or even death. The makers of Invokana allegedly failed to warn patients and doctors of the increased risk of ketoacidosis and the serious complications this diabetes drug can cause. If you or a loved one took Invokana and experienced a serious side effect like ketoacidosis, which led to kidney failure, hospitalization, or death, you may be entitled to compensation by filing a lawsuit. Contact us immediately for a free case review to determine if you are eligible for compensation. No fees unless we collect for you.
So lawyers I don't trust. But when lawyers decide to advertise to the greater community because there is a seen side effect from a drug, then it raises a lot of eyebrows. So do I trust this commercial or do I not trust this commercial? It becomes I get very torn, right? But just know that when you have this particular advertisement side by side with our Invokana advertisement, you can see that what the lawyers, even though I don't trust them, what they said is closer to the truth of what's going on versus what the commercial was trying to pitch to you, right? So there's these two extremes. Now, is everyone going to have kidney damage? No. Is everyone going to have kidney failure or have a hospitalization from a urinary tract infection? Probably not. But I think the point is that there was missing information in that initial commercial that could have helped some patients weigh the risks and benefits of taking this particular drug. More post-marketing data. So 2 years later, you have this. So based on new data, Invokana and all of the new combinations of Invokana increased risk of leg and foot amputations. Some serious stuff. So more words on a page. This is a very boring graph, and it's got a lot of numbers. But to me, it's gold. And the reason why it's gold is because it looks at patients who didn't take it, and it also looks at patients who did take it. And it's all about interpreting these numbers. So let me interpret some of the results for you. You know, they'll have things like 95% CI, which means confidence interval. And what that means is I'm 95% sure that I'm right about these numbers, that this wasn't just a fluke. And when you look at the numbers, it says that your likelihood of having a foot or any amputation, actually. So let me clarify it. Your likelihood of having any amputation was almost double than those who didn't take the medication. So that this particular drug is promising things like weight loss and decreasing your A1C, loving your numbers, and yet you're missing limbs. Let's break it down just by pure numbers. So the numbers over here also tell you, what is it, 3.5%? Or let's see, the likelihood. So when I look at the likelihood, and that's over 3.5%. So that basically tells me if it's 3.5%, patients with an amputation, that means 1 out of every 33 patients who take this drug has a chance of an amputation, right? So if you look out in this crowd and there's a third of you that are diabetic, take another third of that and they might have an amputation if they all took Invokana, right? And so putting those numbers together, I think is more meaningful to say, okay, well, 1 out of 33 people, that's like a 5th grade classroom, you know? And that's a small classroom in California. So why are amputations such a big deal? Okay, so if you're diabetic, and this is a metabolic condition requiring a metabolic solution, like diet and exercise and medications altogether, then you get a leg amputation, and all of a sudden exercise seems a little harder, right? And then when exercise seems a little bit harder, you take that part out of the equation, your diabetes gets worse. And the number one thing that I see that happens to diabetic patients is they go into this kidney failure mode, requiring dialysis. And anyone who gets poked over and over 3 times a week for dialysis may be part and part to infections. And then they spiral down to death. And so I think amputations is a big deal for diabetics, right? So let's look at more lawsuit commercials.
If you or a loved one suffered an amputation after taking Invokana, you may be entitled to financial compensation. Invokana has received a new FDA black box warning for an increased risk of foot and leg amputations. Other side effects include diabetic ketoacidosis, heart attack, and stroke. If you had an amputation after taking Invokana or suffered any of these other side effects, call Miller Legal LLP at 888-804-5755. That's 888-804-5755. Non-attorney spokesperson.
All right. Okay, so let's just snap back real quick to these side effects. So this is what the side effects and the management therapies were for Invokana in 2015. When we were first looking at it and we were first trying to speak with our physician and talk about them. And remember, what I told you was this is about evolving information. So what it looks like afterwards is you can see that, the whole increased cholesterol is, bottom of the ring, not even a conversation, because now leg amputations is a conversation you should be having, right? You should understand that, the managing strategy for leg amputations or any amputations is there's not a lot we can do. And this is a very big surprise to me, the whole amputations thing, because I couldn't see it coming. Couldn't see it coming at all. You could see how the drug works, and predictably you could foresee there would be kidney issues or adverse effects around that area and around that organ system, but I couldn't see amputations coming at all. So this kind of emphasizes how the way to manage some of the information coming at you is understand where they are in their post-marketing data, and don't be the first. Don't be the first. By all means, don't be the first. There's a lot of drugs for diabetes, and commercials may make you think that this has got to be the drug for you. But there are a lot of drugs for the big main metabolic diseases that plague the United States: diabetes, hypertension, and hyperlipidemia. So there's a lot of medications that are here, and you can try all the ones that have long side effects, because then at least you're in the know and you can weigh the risks and benefits that are important to you. So how to manage fact and fiction, we discussed this. Don't be the first. And then also, when information comes to you, how do you focus on what's real if you're going to choose an old drug with a long side effect profile? So in the information overload age, what you should do is recenter yourself and focus on what your goals are with medication therapy. Bring that to your physician, because I think that the physician should know what your goals are so that they can weigh which therapies would help you accomplish your goals. So an example of a goal, long-term goal, for example, live long enough and well enough to dance with my daughter at her wedding. That's a long-term goal. So if there's all of these anti-diabetic medications and leg amputation was one that's plaguing Invokana or Invokana-like drugs, then I'm not going to take Invokana. right? Here's a short-term goal: be able to have meaningful conversations with my wife. So that's a short-term goal. So examples of non-goals. So these are goals that many healthcare providers will give you, and say, "Oh, this is what we have to focus on." And these are really important too, but know that you shouldn't be coming to the table with these types of goals. You should be focused on your long-term and short-term goals, your real-world goals, and then letting your physician help to guide you how to make those goals possible. An example of a non-goal: hemoglobin A1C 6.5% to 7.5%. So that commercial about loving your numbers. I would say love yourself. If your hemoglobin A1C is 7.7 and your goal was below less than 7.5, I think even Dr. Soliman would agree, you're on your way. Don't worry. It's within the margin of error when they're measuring the laboratory value anyway. So don't stress out about your numbers. Do your best and do what you can do to reach your goals of these long-term and short-term goals that you want to accomplish in your life. Personal story. I had my A1C checked, and I was pre-diabetic, and man was I so anxious about getting my numbers down. I did diet, I did exercise, I took no carbs in, I did everything that I would counsel a patient to do. And I did it for a year. I lost 10 pounds. I know I've got nothing on me already. At the end of the day, I decided I'm not going to check anymore because it was just stressing me out because my numbers didn't even change, even though I did all of those things. So don't stress out. Do what you can do. If there's medications involved and you're willing to take those risks, take those medications. And then, talk with your physicians about what your real goals are and let them deal with the numbers and talk to you about how you're doing. Anything else? Also, the last thing, and people don't do this enough, and I wouldn't say this is not on the onus of your physician. It's not on the onus of your pharmacist. It's actually on the onus of every single patient and every single caregiver. Reevaluate your medication list. What are you taking? Why are you taking it? I think people don't do that enough. Every year, you should be asking yourself, well, I'm taking this drug, so what does it take for me to stop taking this drug? When's a good stopping point? And the body ages, and you're still taking the same medications you've taken 15 years ago. Do you think that you're going to metabolize it the same or differently as you age? So keep those things in mind, right? Have you reached your goal? Are you well below your goal? Can you start easing off on some of these medications? And that's the real goal, right? To enjoy your lives as healthy and happily as possible. So now I'm going to go into drug costs. I don't have any commercials for this one, but there's a lot of debate and there's a lot of myths out there about drug costs, why they're so high, and I wanted to help clarify some of those things. So I did a lot of research. This particular article that was published in 2016 let us know that the key items that cause drug prices to go up so high are patent protection and price setting. And we can see that the price of prescription drug medications are outpacing inflation. So that's pretty scary. Here's a part of the problem, and you can see that like countries, Canada, France, Germany, have insulin prices, as an example, far below what we pay here in the United States. It's outrageous. So you can see my theme here. I'm trying to resonate with diabetics here. But it is outrageous to have insulin prices at $300, $400. This is published in 2015. So the actual price is higher than this for us. So understanding why. So I have a little quote that I took from the same 2016 publication. Drug companies, and this is verbatim, this is not even my words, drug companies' ability to maintain high prices in the United States is based on two market forces: protections from competition and negotiating power. So let's go through that. So protections from competition. I believe in capitalism, and I believe that innovators should get paid what they do get paid. But the big but here is that it's not working for healthcare, and it's not working for drug prices. I don't know what will work, but it does have its consequences. So patent law is supposed to help protect the innovators, and small changes in the drug allow for us to repatent things like insulin. So insulin, it's discovered in 1922, is still patented today. Now, patents usually last between 5 to 20 years, and yet 1922, it's 2000 and almost 20, right? So that's almost 100 years of knowing insulin, and yet it's outrageously priced. There is a thing called pay for delay, so where they where when the patent gets filed for these small changes, and these small changes, they don't even have to prove that it works better than the original insulin. They just have to prove that it doesn't work any worse. So what they'll do is they'll pay off anyone who challenges them. So generic drug companies will come up with their generic form of insulin, and they're ready to do the hard work by manufacturing, selling, drug contracting, all that stuff. And then here comes along the other makers of insulin, like Eli Lilly, and then they just pay them to stop challenging. So it never goes anywhere, right? And then they get their repatents issued to them. So negotiation. So the United States does not cap drug prices. And then the competing drug companies often engage in price setting. And then lastly, there's this thing right here off in the middle, pharmacy benefits manager, which is a really complicated thing all in itself. So the negotiating part of this, it has there's a lot of conflict there. And I've kind of explained the pay for delay. So what we should do is we should focus on this competing drug companies often engaging in price setting. So let's take a closer look at that. So here's a great quote. A patient told this to me, and then I looked it up. The road to hell is paved with good intentions. So the team in the intensive care unit and myself, we were trying to treat a specific patient, and he didn't want to be treated. He said, "You guys can stop trying to do this to me. I'm good where I'm at." And we kept pushing and pushing for treatment because we knew that was the best thing to do. And then he told us this, and then it stopped me in my tracks, and it made me rethink what I'm trying to do. Right? I'm trying to do what I've been taught, like the best possible scenario based on the best care, and yet I forget there's a patient, there's a human being there on the other side that says, you know what, I'm actually good where I'm at. I don't want the care because it hurts too much, So over here, the intent for patent extensions is to protect revenue stream for innovators, and yet 78% of the drugs that got patented in the last decade were not new patents on new drugs. So that's pretty shocking. And then even though insulin was invented in 1922 and sold for $1 Canadian from the University of Toronto to Eli Lilly, it now costs something around $429. And this I looked up a couple days before this presentation, and this is what the list price is for Lantus and Humalog. All right, so let's talk about price setting. So the purple and green lines are competing insulin manufacturers. And you can see that their prices are moving upward in lockstep in the last decade. So that's kind of amazing. And a word kind of gets thrown around, So I'm just going to read this definition, and you guys can piece everything together. Cartel, it's a noun. It's an association of manufacturers or suppliers with the purpose of maintaining prices at high levels and restricting competition. So, sounds like a cartel. That's one of the large parts of negotiating, but what about this pharmacy benefits manager? So I'm going to do everything short of calling pharmacy benefits managers evil, because then I'd be calling my wife evil. But they do impact drug costs. Absolutely they do. So here's a map from the Wall Street Journal, and this is an explanation, a pretty accurate explanation of what the pharmacy benefit managers get in return for, their business. So you have the patient coming in, buying a drug for $35, 16 of those dollars go to the pharmacy, and $18 goes to the pharmacy benefit manager. The drug might cost $3, and there it is. There's your $35. And then the drug maker will do something like list it at $137 because they know they're not going to get paid very much, and then the insurance back end will pay for the rest. So that's kind of where it goes there, right? Couple of things about pharmacy benefits manager. Full disclosure, again, I have a wife who works for an insurance company, and her department is like 40 people, and she and her team is responsible for about 800,000 lives. They can't actually do it by themselves. So try adjudicating 800,000 claims. It's quite impossible. That's actually why the pharmacy benefit manager actually exists. They negotiate the terms and they adjudicate the claim, and then they take a piece for doing it. So there's a large number of bodies that are actually working to adjudicate your claims. What would be the flip side? If you had no pharmacy benefit manager, then you might have to pay it all out of pocket and then adjudicate the claim on the back end. So you have to keep your receipts and then send it back in. And actually, there are some health plans that do that so that they can avoid the PBM cost, right? Because they don't have somebody to help adjudicate that claim for you, so all you pay is the copay. So that's the cost of healthcare. Too many people. Just to recap, so why drug prices are so high. So outdated government policies on patent protections increase drug prices for consumers. Challengers to patent revisions are often silenced through settlements, which extends the patents and price protections for drug companies, and PBMs add to the cost of service. Now, I don't know if PBMs are necessary or not necessary. It really just depends on the consumer. Do you like just paying a copay and not worrying about doing the back-end adjudication? And again, that's where when you're shopping for your insurance company, they'll let you know how those things work. So what's the overall impact? So here's a good example of impact. So in 2017, Alex Smith, type 1 diabetes from Minnesota, dies because he couldn't afford insulin. Now, the story goes that this 26-year young person is type 1 diabetes and was going to get off of his mother's insurance in May. That's when his birthday was. Then the pharmacists let him know that his insulin plus all of his supplies would cost him something around $1,300 per month. His annual salary was something like $35,000 a year, and he did find a plan, but the deductible was $7,600, and he had to pay $450 a month. So it's about it's $13,000 versus $15,600. So his plan was, let me go without insurance, and I'm going to try to bargain for my insulin somehow, some way. But he didn't even get to do that, because less than a month after being uninsured, he dies. And he dies from diabetic ketoacidosis. So it's a pretty sad story. But is there going to be any changes? So very recently, the 7 biggest drug companies in the United States came together at Congress to have this congressional hearing where the congressmen grilled these 7 companies on why the drug prices were so high and what they were going to do to change it. So I don't know if you've heard these congressional hearings, but sometimes these congressmen it's not their profession to know the details of the system, and so they're not well adept to ask the right questions or push the right buttons. Also, there's about $174 million in 2018 that was lobbied by the big drug companies. And so as they're asking these hard questions, these congressmen are asking these hard questions to these 7 drug companies, you might want to ask yourself, well, what are we really doing? Are we just asking questions? Because the same themes keep coming up, right? They blame prices on rebates on the PBMs. They don't want our government negotiating prices directly with Medicare because it's more socialistic than it would be capitalistic. They acknowledge that they do receive profit from in other countries for the same drug, but argue that if they didn't charge the United States this type of price, they wouldn't be able to do the type of research and development that they are currently doing. So they have all of these excuses. So they're excusing themselves on one hand, blaming other people on the other hand, and then we as the consumers are continuing to pay the high prices. So whether it comes out in your insurance deductible every month, or if it comes out of your pocket, it's that list price that's really high, and the middlemen that are eating up all of the costs. So with that, I'm just gonna end my conversation about drug prices. Hopefully answer your questions in the panel. Thank you.
Okay, we're just going to take a couple minutes for people to be able to stretch and go to the bathroom. Rather than taking time to collect questions because we've run a little bit late, I have a handheld microphone, and I'm just going to let people raise their hands. I'm going to come to you, but that way you'll be able to speak into the microphone and we can address the questions to the panel. But go ahead and take a couple of minutes to stretch, go to the bathroom, and then we'll reconvene. Be thinking about your questions, but I'll come to you with the microphone. So I'm going to go ahead and ask people to start to make their ways back to the seats. And that way we can get a few questions in and still finish on time here. All right, so what I'd like to have you do now is just, if you have a question, go ahead and raise your hand. I'm going to just make my way from the audience and let them address the question.
My question is, if a black box med is prescribed by a doctor, does either the doctor or the pharmacist have to explain to the patient that a black box med has been prescribed?
Yes, I believe that any kind of medication side effects in general, whether it's black boxed or not, should be explained to the patients, what to expect and what to expect, not to expect. So I think definitely my answer will be yes, especially if there is any severe danger, like as he mentioned, leg amputations, heart failure, any life-threatening side effect should be discussed. Yes.
In terms of black box warnings, and consultations by a pharmacist. So if you're taking a medication and it's new, and it's the first time you're taking it, the California law does require that a pharmacist speak to you about your medication and potential side effects, which would include black box warnings, but you may also decline it as well. So it's when you get to the window and you sign off whether or not you've acknowledged you received a consultation. That's the time that you're either accepting or declining that consultation.
Do you mind just for the crowd here, what is a black box warning?
Oh, a black box warning is a warning that the Food and Drug Administration deems necessary to put onto a medication based on studies that have been done, or because it's in a drug class that has previous studies in it. It's not always a absolutely do not use this drug kind of deal, but it's a strong warning that usually heeds physicians and pharmacists to avoid the drug altogether.
I think I saw.
I have a question about false advertisement. Why does the AMA, the Federal Trade Commission, and the Federal Communication Commission permit false advertisements? Are they all in the payoff?
I believe they are. Yes, I believe it's all about money, I guess. And I think the drug companies are very rich and able just to hide some of these very, very scary side effects. And that's also a problem. The healthcare has a lot of pitfalls, and I believe that's one of them.
I also wanted to add that we spoke briefly about the evolution of information. And in post-marketing data, you see more of a clearer picture. And so many lawyers will try to reveal that evolution of information. Oh, I didn't know it until this moment. And it's what you prove in court. So the good guys who are fighting for you, who are rooting for you, and trying to protect you as a consumer, it's an uphill battle, because it's what can you prove that they knew at the time while they were advertising. And I think that's the hard part. So there are bad players and bad actors in the industry, absolutely. But it's hard to see which ones are the good ones and which ones are the bad ones, because we're having to fight this evolution of information.
And a good example of that is, in the short time that I've been in medicine, about 25 years, when I went into medicine, everybody was putting everybody on hormone replacement. Then we had a big study that said, wait a minute, hormone replacement is bad, and we took everybody off of hormone replacement. Now the pendulum has finally swung back a little bit, where we say, hey, let's identify the people that would benefit, that don't have any risk, and let them have hormone replacement. But there are people that are at risk that should not have it. So people are people, and you're going to see these kinds of swings in information as we learn. And that's the problem. Medicine is an ever-evolving science and art, and we don't know everything that we need to know. So it is a process, but then again, the process gets hindered by the bad players. I think I saw a question here.
You mentioned atorvastatin as one statin that could affect one's brain. I've been on the stuff for several years. Should I see my doctor for something different?
Well, it's a big controversy since that occurred, since they came up with the studies, because in the past we used to give patients Lipitor, and they say, hey, there are some studies say that it can improve your memory. And that's because they understood that it can cause the blood-brain barrier. They came back with the studies saying, no, it can cause memory loss, especially if someone has a high risk factor or family history of dementia. So if you ask me, I don't think it's an emergency, but if that was me, I will change it. I will change it to Crestor or something else that, knowing my family history, I don't want to have dementia.
Thank you.
You're welcome.
Okay, here's one here.
Yes, since the beginning of last year, California is one of the 2 states, along with Massachusetts, that don't allow us to use manufacturing coupon. And that cost me personally, put up many hundreds of dollars per month. So I was wondering, is there, I'm sure there's a lot of brand name medicines that are not the same as the genetic medicine. And so by that law passed, I don't see the brand name drugs going down in the near future.
So I'm not sure I understand your question. I think the generic medications do carry the good effects and side effects just like the brand ones. The one I prefer the most to be a brand only and not a generic is the Synthroid, the medication for thyroid, because somehow they work much better when they're brand, not a generic. So that's what I understand about the difference between brands and generics. So I don't think I got your question correctly.
Yeah, I'm taking like tree medicine for glaucoma eye drops.
Okay.
And I understand that some of the release mechanisms are not the same, you know. So, and I also take Synthroid and Crestor and Repafol and all those brand name medicines.
Crestor, the generic, the rosuvastatin is similar. The Synthroid, as again, I think that's the one that you should be taking the brand for. Most eye drops or most glaucoma medications, generic and brands usually give equivalent effect. So I don't think you're going to have any major kind of improvement with the brand versus generic for the glaucoma medications. What do you think, Dr. Pham?
So the brand versus generic conversation is a very interesting one. So in the United States, when you have a manufacturer that manufactures drugs in the United States, the FDA is supposed to come by and check up on them. What you'll notice is that some of the generic manufacturers are not located in the United States, and there are a lot of generic manufacturers. It could be manufactured somewhere, you know, in the Asian continent, like India or China. And so the question is, are the manufacturers there up to snuff with regards to what they're supposed to produce? Are you getting what you're getting? When they produce their initial drug to compare with the brand, it's supposed to have a plus or minus 10% potency. So at that time, they are proving that they're doing what they're doing. But over time, when the generic companies are you know, lay to do what they do, is you know, are their practices eroding to a point where you're not getting what you're supposed to get, right? So is the FDA doing, the question should be, is the FDA doing their job policing some of these manufacturers that are offshores, that the generics are indeed what they're supposed to be? What I was taught was that it's supposed to be the same. Right? But again, my bias is when I'm looking at a generic versus a brand, I can see that the cost to my pharmacy is less and my margin is higher when I use a generic. So as a pharmacist, I'm biased to want to give you a generic. I think my graduation, when I graduated in 2010, one of my preceptors had actually fought the Synthroid company on brand versus generic. And so again, you know, they did everything that they could do litigiously to make her life a living hell. And she fought it tooth and nail. And there's actually data out there that says Synthroid brand versus Synthroid generic is actually the same. How much of that is true, you know, right? So, you know, based on Dr. Soliman's experience, she can hear from her patients, hey, you know, this Synthroid is working differently than this, you know, levothyroxine generic. And so it really depends on patient to patient, like, or drug to drug, patient to patient, what's going on with these brands and generics. So it's a very hard question to answer straightforwardly. But again, you have biases on all ends, and then you also have issues with government policy and government enforcement. And I think that's where the problem is most, that needs most attention. Because I'm not sure that these drug companies, brand or generic, are getting the scrutiny that they deserve to ensure that we're getting the product that we're promised.
So I think we'll just take one more question.
I'm curious your thought on this. I feel that the supplementation world should have more control and standardization, because I get a tremendous help from supplements. I've even been able to get off of brand name things like Allegra, taking bromelain and quercetin. My allergies are really better even. So, do you know anything? What could be done that supplementation could be standardized, I guess I'd say, better, followed better?
Well, I agree with you in many ways about the supplementation now, and the more approach towards natural and holistic. However, there is not enough evidence in many of the available over-the-counter supplements for the safety level or for any scientific data that can support many of the claims. However, nowadays, with the American Academy of Family Physicians, you see more and more research has been done, and even every time I get more information about new herbs or new supplements, and I look under the American Academy of Family Physicians, even the WebMD, you can see that there is a lot of now research and more popularity towards supplements and how can it help. So as a physician who studied traditional medicine, I just try to be as wise as I can be and not just going through the holistic world without knowing enough data or science behind it. Do we need more research about that and more? Yes, we do. And I think that will be great because most medications are coming from natural supplements. However, some of them are mixed with other things, synthetics, that can be harmful, as we saw that there might be some side effects of some of the medications. So I agree with you, yes. You're welcome.
I just wanted to add about food and drug. There's a very thin line between the two, right? Some really great examples. Red yeast rice does the same thing as a statin drug would do, and yet they're not regulated. So there is this group of herbal supplements that are not being regulated, and they should be, and yet the FDA isn't seeing that the product that they're promising you inside the package is what it is, and that it's safe for you. So they can do anything they want in the herbal supplement area or world, and just be very careful about what you're moving towards, or wanting to take, or wanting to additionally add to your therapies. Discuss it with your physician. Absolutely. I agree with Dr. Soliman that there's sparse data out there, but if you take it one step at a time and see what is out there and discuss it in lengths of in terms of like risks versus benefits, then you can see whether or not that particular herbal supplement is good for you.
Yeah, also I just want to add that there is some kind of herbs now with the American Academy of Family Physicians, like the omega-3 fatty acids, 100% can be highly, highly recommended for a high level of triglycerides, and it does work. There's not one patient who took the recommended amount of the 3,000 milligrams of omega-3 fatty acids and their triglycerides did not go down. People who has fatty liver caused by excessive amount of cholesterol in their system, if they take, there is American Academy of Family Physicians study about milk of thistle. Milk of thistle is an herb that's sold at Trader Joe's and Whole Food, and it was found and proven to help with fatty liver. So there is a lot of some herbs that are now used with traditional medicine to help patients for certain conditions, like fatty liver, for example, that we didn't know what to do besides diet and exercise and improving the cholesterol. It does clean it.
All right, I think we probably have enough information here for about 3 more talks, but we're going to end for tonight. I'd like to thank our panel for all of their good information.